Hello, everyone. My name is Lisa Nunes, and I'm a current graduate student in the Psychiatric Mental Health Nurse Practitioner program at UTEP. I've been a nurse for 4 years now, working in the pediatric ICU as a school nurse in elementary and high school, and in psychiatric or behavioral health inpatient care. Across all these settings, one thing has remained constant I've seen: unsafe staffing ratios despite any specialty. I've watched it play out over and over again, either for myself or viewing my coworkers, where nurses have been stretched thin, patients have been waiting longer for care that they have expected or longer than they should, and care has been compromised because there simply aren't enough nurses to take care of all the patients that have been thrust upon them in unsafe patient assignments. Let's talk about the reality here in Texas, which is where I practice nursing. There's no formal safe ratio law here for nurses in any specialty. This lack of regulation often leaves staffing decisions up to individual hospitals or administrators, and it's burning out our nurses here in Texas and putting patients at risk. This is evident because back in September 2024, according to an article from the National Nurses United, nurses at Ascension Seton Medical Center in Austin had had enough. They had submitted over 300 despite objection forms due to unsafe assignments, and hospital administrators had looked at that huge number of forms and had not done any action. Nurses, according to this article, had rallied to show how they thought this level of unsafe ratios had really impacted them and their patients. Now, in comparison, we can look at California, which is the only state that has a law that mandates safe nurse to patient ratios. Another National Nurses United article explains that those ratios have to be maintained for every hour of care that the hospital is open. So basically, whether a nurse is on break or on the floor, these ratios must be maintained through safe staffing. Some examples are one nurse to one patient in trauma, one nurse to two patients in ICU. The biggest one nurse to five patients in medical surgical nursing, or one nurse to six patients in psychiatric nursing. These numbers aren't just for policy, they're for patient and nurse protection. They protect nurses from being overloaded, and they protect patients from being overlooked. That's why I believe the US needs a federally mandated unit-specific nurse-to-patient ratios to account for acuity, age, and demographics of patients nurses are caring for. Leaving it up to hospitals and individual states just isn't working. Texas is proof of that, with the mentioned rallies from the previous articles I had mentioned. We need consistent enforceable laws that actually put patient safety first. Research also backs this up. An article by Lasater et al. Shows that nurse staffing ratios are directly tied to patient safety. California implemented its law back in 2004, and no other state has followed suit in over 20 years. 20 years this issue has been brought to the forefront of nurses, and no hospital or state has really taken action except California. The data is powerful in this article, and one line that really stuck with me as a nurse was this direct quote from Lasater et al., which was, "Each additional patient in a nurse's workload increased the odds of patient death by 16%. The study also went on to say that if the study had continued, it was projected that data would have shown that staffed medical surgical units properly would have had 1,595 deaths that could have been prevented among Medicare patients alone. To me, that's staggering, and that really shows the importance of this unit. Yes, nurses are being burnt out by having too many patients, but at the end of the day, what we care most about is patient safety and patient outcomes. Better staffing can cost the hospital money, but how can hospitals justify saving money by cutting corners and risking patient lives or safety? I know some of the ideology between patient to nurse ratios is flexible staffing helps hospitals deal with changing patient loads on the unit. While in theory this might work, in practice it ends up just being an excuse to have chronic understaffing because hospitals cannot accurately project night to night what their patient acuity might look like. It's become a way to cut corners and not improve care. Nurses and patients end up paying the price. So, what can we do? Plenty. Nurses can become lobbyists and support the Nurse Staffing Standards for Hospital Patient Safety and Quality Care Act. Or on a smaller level, they can support organizations like the American Nurses Association, who, in an ANA article on their website, made it very clear they had a strong stance supporting the Nurse Staffing Standards for Hospital Patient Safety and Quality Care Act. While not every nurse can be a lobbyist trying to influence lawmakers to push this federal law forward, nurses on a smaller level can also advocate within their units or hospital system for safe staffing depending on their patient assignment. They can also stand behind their local union for strikes to really rally behind each other and, as a united front, push the message to their hospital how important safe staffing is. There are different ways to advocate, and every effort matters. Some of us fight on a national level, and some nurses have conversation with management, but all of it pushes the movement forward. I firmly believe it's a nurse's responsibility to advocate for safe ratios and patient safety, whether it's through small efforts or big ones. We owe it to ourselves, we owe it to the field of nursing, and most importantly, we owe it to our patients. Thank you so much.